All right, welcome to The Explainer. Today we're going to do something a bit different. I want you to imagine you're stepping into a clinic because we're going to solve a real diagnostic challenge together.
So let's just dive right in. Picture this. You're the doctor. You walk into the exam room and your new patient is there. She's 32, a nurse, so she's seen this all from the other side. Now, it's your turn. You've got to listen, look for the clues, and figure out what's going on. It's a real puzzle. You ready?
Okay, so where do we start? Well, every single diagnosis, it always begins with the patient's story. So let's hear what she has to say.
So here's what she tells you. For about a year now, she's been getting this intermittent pain and swelling. It's in both her hands and her wrists. It'll flare up for a few weeks and then kind of go away. But lately, things have gotten worse. Now it's spreading to her knees and ankles. And listen to this. This is a huge clue. She says in the morning, the stiffness is so bad, it lasts for hours. I mean, she can barely get out of bed, let alone get to work. On top of all that, she just feels, well, sick. A deep, crushing fatigue that's way more than just being tired.
All right, her story gives us our first big set of clues. But a story is just one part of it, right? Now we need to get some hard, objective evidence. So it's time for a physical exam and some lab work.
In your exam, it totally backs up her story. You can see it and feel it. There's swelling, redness, some real tenderness, and it's on both sides of her body. Specifically, you're seeing it in the middle joints of her fingers. Those are the PIP joints, and also the knuckles, the MCJ joints. Wrists and knees too. That symmetry, the fact that it's happening on both sides, that is a really, really critical piece of this puzzle. You also check her skin. No rashes. Good. That helps us rule a few things out.
Okay, now for the blood work. This is where things get really interesting. First off, her white blood cell count is normal. So a standard bacterial infection, probably not what we're dealing with. But then you see this. Her ESR, that's the erythrocyte sedimentation rate, it's at 75. Now for context, that is way up. It's a massive red flag that there's some kind of major inflammation happening all throughout her body. We're also seeing she's a little anemic, which, is pretty common when you're dealing with a chronic inflammatory condition.
So let's take a breath. You're the doc, you've got the story, the exam, the labs. Let's recap. Symmetric joint pain, morning stiffness that lasts for hours, and an inflammation marker that's through the roof. What are you thinking? What's your #1 suspected diagnosis right now?
All right, let's see if your gut feeling was on the money. Time to put a name to this.
If rheumatoid arthritis was your answer, ding, 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 you nailed it. It just fits perfectly, doesn't it? The symmetric inflammation, that crazy long morning stiffness, the blood markers screaming inflammation, everything is pointing straight to RA.
But what is rheumatoid arthritis really? Well, it's a systemic autoimmune disorder. In plain English, that means the body's immune system gets confused and starts attacking itself. In this case, it's going after the lining of the joints, the synovium. And this constant attack creates this chronic, symmetric inflammation that can literally eat away at the joint if you don't stop it. But listen, making a diagnosis isn't just one aha moment. It's a whole process. So, we've already checked off step 1. We've confirmed there's inflammation, thanks to that high ESR. So what's next? Well, now we need to get more specific. We're going to order some antibody tests to really nail this down. And the big one, the key test we're looking for is called rheumatoid factor, or RF.
But hold on. A really good doctor doesn't just stop at their first guess. No, you have to play detective. You have to consider the lookalikes, the other conditions that could be masquerading as RA. So let's talk about the biggest imposter out there.
And this image here shows the difference so clearly. On the left, you've got RA. See how it's hitting the wrists and those big knuckle joints? Now, look over at the right, at osteoarthritis. Totally different pattern. It goes for the small joints way out at the fingertips. That pattern where the disease attacks is a huge, huge clue.
Let's dig into this a little more because the differences are critical. Remember our patient? Her morning stiffness lasts for hours. With osteoarthritis, you're usually looking at less than an hour, maybe just a few minutes. And her arthritis is symmetric, both hands, both knees. OA? It's often lopsided, just one side. See, this isn't some wear and tear issue. This is a full-body inflammatory assault. And telling them apart is everything, because the treatments are completely different. So, how do we get from pretty sure to absolutely certain? Well, it turns out there are official criteria, a sort of diagnostic fingerprint for RA that can really help us lock it in. So here's a kind of checklist based on the official criteria. Let's run our patient through it. Number 1, morning stiffness for more than an hour? Yep, she's got that. Check. Number 2, arthritis in at least 3 joint areas. We've got hands, wrists, knees. So, check. Number 3, arthritis specifically in the hand joints? Big check. And finally, number 4, is it symmetric? Is it on both sides? Absolutely. So, check. Wow, she just sails through this checklist. This makes the RA diagnosis incredibly strong.
And remember that rheumatoid factor test we talked about ordering? Well, here's why it's such a big deal. Somewhere between 80 and 85% of people with RA test positive for it. So when her result comes back positive, and we're expecting it will, that's not just another clue. That's pretty much the final piece of the puzzle we need to be sure.
And this is why getting that diagnosis right and getting it early matters so much. These images show what can happen with advanced untreated RA. On the left, that's called a boutonniere deformity. On the right, a swan neck deformity. This kind of damage to the joints is permanent, it's irreversible, and preventing this, stopping the disease before it gets to this point, is the entire goal of treatment.
Okay, so we've got the diagnosis. We've solved that puzzle. The conversation now has to completely shift from what is this to, okay, what are we going to do about it? Because this isn't something you can just cure with a pill. This is about managing a chronic condition for the long haul.
And this quote really says it all. The structural damage to the joint is irreversible. Once it's gone, it's gone. So our entire strategy, our whole goal, is to jump in and stop this disease in its tracks before that permanent damage can even start.
The good news is we have an amazing toolkit to fight back. For day-to-day symptoms, we can use NSAIDs. Think of them like putting out little spot fires. If there's a big flare-up, that's when you bring in the corticosteroids. They're like the fire extinguisher, fast and powerful. But the real game changers are the DMARDs. These are the drugs that actually slow the disease itself down. They tackle the root cause. And for the really tough cases, we've got these incredible biologic agents. They're like guided missiles that go in and target the very specific molecules causing all this inflammation.
So we did it. We solved the clinical puzzle. But that's not really the end of the story, is it? For this patient, our 32-year-old nurse, this diagnosis, it's just the first step on a very long road. A chronic illness is going to change everything, her work, her personal life, how she sees her own future. So the real challenge, when you think about it, isn't just treating the disease. It's about managing a life. What does that journey actually look like for her? That's the question we're left with.